Hi there, it's Dr. Russ. About 3, 4 months ago, I did a session with David, who, by the way, is 68 years old, and I diagnosed his right shoulder with a bicipital tendinitis. And I gave him some instructions for self-care, which is what he was looking for. And he came back in a few weeks ago and we did a video of this follow-up session. His shoulder was much better and he just wanted a little cleanup on it. So it was a good session and I thought it was a good video, but when I got home, I realized listening to the video that the sound didn't work. So here it is with a voiceover. And as it's been several weeks since I did this session, I don't entirely remember what I did. And so we're going to watch it together for the first time. And you'll see me discovering kind of what I did while we're doing it. If you're new to the channel, welcome. I'm Dr. David Russ. I'm a chiropractor. I practice in Portland, Oregon. My practice is very heavily soft tissue, myofascial work. I do a lot of structural adjusting, but I really like to show the soft tissue work because I think it's really effective. And I think it's something that a lot of other practitioners could benefit from watching. So whatever your reason for being here, I welcome you. I welcome your comments. In the video description, there'll be a few suggestions for you if you want to support the work that we're doing. We appreciate every little bit. So thanks again for being here. Here's the video. As always, we want to start with a nice, gentle survey. There's a few things that we're able to do when we do this. One is get the patient used to our touch, to sort of assess their overall tone. If a patient is anxious about the visit or maybe about being touched or maybe that I'm going to cause them pain, we'll be able to feel the tension in their body and adjust our touch and adjust the pace of our work accordingly, and also kind of adjust how we talk to them about it. So here I'm getting into a little more actual assessment. Every time I'm rocking the body, I'm just kind of feeling how does it respond to being rocked. And with practice, you can feel each spinal segment, each vertebra rocking in relation to the one above and below. So there's just like some gentle posterior to anterior or P to A pressure. And finding there around his right, looks like thoracic erector, we can see there's hypertonicity there, and that's finding a trigger point with my index finger and kind of following that top band all the way down to where it starts to relax. It looks like the tautness and tension really does blend all the way down into his lumbar paraspinals here. And so now as I press on his pelvis, I'm sensing the ability of his lumbar spine to adapt to that movement. So yeah, he came in with a shoulder problem, but as always, we want to look at the whole thing. And I think what I'm seeing here is that I'm finding a little scoliosis. Left lumbar convex, right thoracic convex, which would tend to correlate with right shoulder problems because the convexity of the thoracic spine on the right side displaces the shoulder blade. The scapula gets protracted, and that creates strain on the ball and socket and makes it more difficult for really all the muscles of the right shoulder to be happy. And so we cannot correct the scoliosis, but we can work with the flexibility of the spine. We can work with the flexibility, pliability, and mobility of the myofascia. That's a big part of what I'm always doing. So I'm still assessing here. Doesn't look like there's any treatment happening yet, but finding graininess and trigger points in that middle and lower trapezius on the right side. Those are the muscles that are trying to keep the shoulder blade in its proper retracted position. And the neutral position of the scapula is not protracted, it's more retracted. So there's always a little bit of a tug of war happening between the rhomboid mid-lower trap on the back and the pec on the front. And of course, the pec is, being the flexor, is going to generally be the stronger muscle. And in a lot of people who exercise and work out, a lot of us tend to favor pushing movements over pulling movements because that develops the muscles that we can see in the mirror and we can see when we look down at our body. So for better or for worse, that's just something we are all dealing with. So we tend to see more issues in the scapular retractors correlating to their being a little bit overpowered. So here David is face down still, and I'm seated, and it looks like I'm interested in getting more into his rotator cuff. So here with my left hand palpating along his infraspinatus muscle, his teres minor, and getting a sense of the mobility of the skin and superficial fascia, as well as the muscular tissue. Coming a little farther inferiorly along the scapula to feel the teres minor, and then right along that scapular border for the teres major and latissimus right there. So my left hand, the fingers are on the front of the lat, and with my right thumb, I'm getting a little sense of the texture and tone of that muscle. Very, very important shoulder muscle. And as a provider and as someone who wants my practice to grow, and if you are the same, please know that a lot of your fellow colleagues are not looking at the latissimus. They don't know how to work around the axilla, and they're missing out on that. And so not only are their clients not getting the benefit of that work, but when they come to you and they do get the benefit of that work, it helps you stand out. I love to assess the glenohumeral joint this way. My left hand or the inferior hand is cupping the ball, the glenoid, the head of the humerus rather. And now I can retract and protract, so getting mobilization of that whole right shoulder girdle without putting any extension through the ball and socket, because that ball and socket is totally supported. And so here we're going to get a little traction and abduction, just playing around that 90 degrees of abduction, approaching it, and then coming up to about 110 and moving through. And that's such an important range because you can really see that that's where the scapular movement becomes so important. When you hit about 90 degrees of abduction, you haven't maxed out the abduction in the glenohumeral joint, but you've put a lot of tension on the glenohumeral capsule. So most of the remaining abduction is going to come from the spin or the glide of the scapula on the rib cage. And that's so important, that scapulohumeral rhythm. It doesn't have to be perfect, but if it's not right, the person's going to feel tension in their shoulder. Eventually, that's going to come up with some rotator cuff issues. So I'm able to support his arm, and he's able to keep it really relaxed. You can see how relaxed his muscles are and just kind of how gummy that whole shoulder is right now. It's allowing me to feel along the triceps, and it looks like I'm palpating along the distal deltoid onto that intermuscular septum and doing some gentle releases there on the triceps. Yes, where the triceps inserts right onto the scapula and then coming down. That's a really important spot too, because the radial nerve comes right through there. And whether the person's having radial nerve type symptoms, which would be tingling, usually tingling in the back of the hand, if there's entrapment or some restriction of that nerve, the body and the brain and nervous system are going to create a lot of change in order to preserve the safety of that nerve. In other words, the body will prioritize the wellness of the nerve over the wellness of the joint or muscle. So it looks like what I'm doing here is doing a little post fascial release assessment to see the mobility of the glenohumeral and that scapulohumeral rhythm. And I always wanted to ask myself as I put a joint through its range of motion is like, where do I feel that restriction coming from? And it looks like I'm going for kind of the meat of his latissimus right there, and looking to, yep, with my left hand, I've got a pretty good pinch on his lat, and with my right hand giving a little traction. And let's see if I'm going to do a static hold here, or if I'm going to put some movement through there. It looks like static is what I felt. That would tell me I've found more of a trigger point than a fascial restriction. If it's a fascial restriction, I'm going to want to move it through and create mobilization with the movement. And if it's a trigger point, I'm going to want to do more of a static hold, just putting the muscle in a position such that I can access those uh, hypertonic fibers and give them a fairly brief but pretty direct compression. And in doing so, squeezing stale lymph and blood out and kind of stimulating what we call the sarcomere, the little tiny on the cellular level segment of the muscle to relax. And trigger points are all about fatigue in the muscle. Can talk about that mechanism in another video. So the main antagonist of the latissimus is the upper trap. And so here I am assessing his upper trap, getting pretty deep in there, I must say. Looks like he's able to relax into lots of deep movement. And so now that attachment of the upper trap to the cervicothoracic junction and feeling the tendon of that trap as it comes all the way up to the occiput in my left hand, kind of holding the occiput, feeling all the way up. So all the way out across the nuchal line, just getting a sense of his whole trap. And it's good to remember as providers that your assessment should kind of feel like therapy to the patient. It should feel good when you are palpating their muscles. So now looks like we're going to go a little TLC to his left side, the asymptomatic side. It's always nice to balance people out at least just a little bit. And let's see where I'm going with this. So these strokes are from iliac crest up the latissimus, which ends at T6. So it looks like I'm working the latissimus dorsi because I'm also pretty superficial. And here I am. Yes, definitely following that lat up to the shoulder. Up to about T6 and then out. So the pressure is coming through the right hand and the left hand is just kind of guiding. I want to take this moment to express my gratitude to David for joining me in making this video and anyone else who's done video stuff with me. It's really an honor and I enjoy doing it. So we're looking at his scapulohumeral rhythm again on the left side. It's really important. Now I've got his left arm in one of my favorite positions. So the upper arm is draped over my thigh. And this way I can really control just a tiny little bit of traction, just a tiny little bit, which allows me to feel. There, his supraspinatus is where my right fingertips are. And I'm feeling for its mobility as it comes through the subacromial space, yeah? So I'm giving a little traction to the arm and a little rotation to the whole shoulder complex to make sure that that supraspinatus feels nice and mobile. And this particular patient is pretty well-developed musculature. I want to say actually for his age, he is what I would say remarkably fit. I think, I'm not exactly sure, I'd have to check this, but he's late 60s or maybe around 70 and just in terrific condition. It's always fun to see. Hard work goes into that. It's also a lot of luck. So here I'm looking at the acromioclavicular joint. There's the end of the clavicle and moving the acromion now with my thumb and just getting a, ooh, look at that pinch. So really moving that. It looks like there's some stuckness there in his, yeah, you can see it twanging. That would be his supraspinatus tendon. So we want to be gentle with that. We don't want to crush it or fray it at all. It's not a very robustly vascular structure. So if you injure it a little bit, it's going to cause the patient problems for a while. So just a few passes directly and then the rest more gentle and indirect. And now more of a general work on his deltoid. And that supraspinatus looks like it was what I was really focusing on. So we're just going to give that a break. Let's see what comes next here. You know, I love working side lying on the shoulder. So we're back to his right shoulder. What I love about working side lying, if the patient can relax, I can hold that elbow and I just have total control over the humerus. And we can get the ball to kind of nestle down into the socket of the joint. We can really feel what that feels like. The glide of the hyaline cartilage on the head of the humerus in the glenoid fossa. Here you can feel if there's irregularity on the labrum. You can often feel that. And I can also feel for the movement of the scapula and really get all those intercostal muscles and latissimus and especially serratus anterior accessible, exposed to my visual examination and exposed to my touch. And it looks here like I'm more on the teres major, and there with my thumb working on his serratus lat junction. If you've watched my shoulder videos, you know that I'm constantly on every patient wanting to make sure that the serratus anterior and the latissimus dorsi move really well in relationship to each other. For one thing, it's really important to scapular movement. For another thing, it's really important to the breathing, because if the ribs are not moving well, you can't breathe very well. And it's also really important to the mobility of the thoracic spine. Here's a little tip to chiropractors out there or anyone who's licensed to do spinal manipulation. If those thoracic segments feel stuck to you and they're not, quote, going, you can't get the movement that you want, look at the serratus. If that serratus is really tight and restricted, it's going to bind up those ribs. That's going to bind up the thoracic spine, and your thoracic adjustments won't go. So here we're stretching him into full abduction with traction. This is a pretty intense movement, while my right thumb is kind of pinning the inferior attachment of the teres major. So we're getting a stretch from the triceps through the teres major, from his elbow all the way to the inferior tip of his scapula. Feels so good. I love doing that to people. And I think, as I recall, David really appreciated it too. Yeah. So he's in full abduction now. He can relax in a fully abducted position, checking back in with his triceps as we had checked in with it before. Looks like I'm feeling a little more bunchiness and some restriction through that distal triceps. And you can see how well defined his arm is. He's just in such great shape. And I don't remember what we were talking about, but I do know that this particular patient always comes with questions, which I always really appreciate his questions. It's very thoughtful. And I think we're going to be finishing up here by looking at the front of his glenohumeral. Yeah, so right there, my finger's on the joint line of the glenohumeral right there, just lateral to and underneath the coracoid. And we're going to look at that subacromial space, that biceps tendon running right there between my fingers. And want to make sure all of that stuff is nice and mobile. Stroking up the tendon of the biceps with a tiny little bit of traction on his arm. And it looks like we're going to make sure that as he abducts the shoulder, there's good movement through the pec, where the pec crosses the long head of the biceps there. So important. So I've really got his arm by the elbow and very, very gently but directly putting a stretch through the glenohumeral. As we're bringing it into abduction, I'm pulling a little bit of inferior traction. I mean, really gentle, because we don't want to obviously dislocate or destabilize the shoulder, but we want to make sure that that ball really glides and rolls in that socket really smoothly. And that's what we're doing. So it does take some experience, to know how much pressure to use. And I suggest, as you're learning, you be conservative, because you can always give it another pass. You can always ask the patient for another session. But if you go too hard and you injure them, or even make them more sore than they really wanted to be, sometimes it's hard to come back from that. Looks like he's happy with the movement, and it looks like I'm getting ready to wrap it up here. So, hey, thanks for watching. I hope you've enjoyed my little voiceover. And this is Dr. Russ signing out. We'll see you on the next one.